Okay, we will get going. So, yeah, welcome everyone. I hope everyone's doing well. So I'm Matthew Hill. I'm Head of Insight Evaluation and Research at Q. So great to see everyone on the call today. I think we'll have a few more joining us over the next few minutes. Today, we're going to be hearing from Professor Sally Lewis, who's going to share insights from her book, Implementing Value-Based Healthcare, an insider's guide to improving patient outcomes and creating sustainable systems. So this is my copy here that's well thumbed and read over Christmas. Really kind of compelling and human actually account of kind of Sally's work to lead the implementation of value-based healthcare in Wales. Before I say more on Sally and introduce her properly, I'm just going to take a couple of minutes to make sure you've got everything you need to get the most out of the webinar. So for those of you who are not yet part of our Q community, we'd love you to join us. We're a large and diverse community reaching across the UK and Ireland, and collectively we collaborate to improve the safety and quality of health and care. Sally, could you just move the slides on, please? Great, so this slide just shares a bit more about Q. Q is free. We ask for kind of commitment and enthusiasm, and in return, you get access to a whole range of member offers and opportunities to connect, learn and share with others across the UK and Ireland. So do take a look at that. Part of this webinar will be Sally responding to questions. So please do add your questions to the sidebar, to the chat box throughout the conversation, and we'll come to those at the Q&A.
You just went on mute. Matt?
Oh, sorry about that, Shah. So I was just saying, part of the webinar, Sally's going to be responding to questions. So please add your questions to the sidebar throughout the discussion, and we'll come to those in the Q&A section. There are closed captions available. If you'd like them displayed, please click on the bottom of the screen under More, where you'll see the CC button. Just click that and you'll get access to the closed captions. And we are recording the session. We'll send a follow-up email afterwards with links to the recording, some resources, and the slides, so you will get access to the slides afterwards. So I'm really delighted to introduce our speaker, author of the book and Professor Sally Lewis. She's been a GP for over 20 years, is now an independent strategic advisor on the concept of value in healthcare through Kintsugi International, which she founded. She also serves as Professor of Value and Health Management at Swansea University and was formerly National Clinical Director for Value-Based Healthcare in Wales, where she established the Welsh Value and Health Centre. So we're feeling really lucky and very grateful to have Sally with us today, and really looking forward to hearing more from all of your experience in value-based healthcare and system transformation. That's enough from me. Over to you, Sally.
Thank you, Matthew, and hi everybody. It's great to see you all on the call, and I see that some of you are here in groups as well, sharing lunch, I hope. So it's really great to see you all. So today we're going to talk a little bit about how we achieve value in healthcare systems. And I'd really like to share with you some personal reflections about why I got into this work in the first place, and why I think this is such a helpful lens through which to look at the problems that we're facing in healthcare today. Because, as you know, we're under increasing pressure in the NHS. But actually, as I begin to work internationally, what I'm seeing is that actually these problems are the same everywhere in the world. They just play out slightly differently depending on the context. So value in health. And I'd like to begin, I think, by telling you a story, because if you'll indulge me, this is why really I came into value-based healthcare in the first place. And it's about moral injury and the moral case for change. In 2012, on a typically busy Friday, I was sitting in my consulting room in my primary care practice in an old mining town in the South Wales valleys. I was on call, meaning that I could expect around 60 patient contacts between 8 and 6:30 p.m, 45 of which would be face-to-face. I also had 2 scheduled house calls, one to an elderly man with complex comorbidities and no family living nearby, the other to a lady with cancer in the terminal phase of her illness. The latter was a lady who was very well known to me. She needed coordinated palliative care so that we could care for her at home in her dying days, as was her wish. I was really stressed. There were a lot of problems to sort out and not enough time to handle them in the manner I would have wished. Towards the end of the morning, another of my regular patients came to see me. Janice was in her mid-50s and had recently been diagnosed with a chronic pain syndrome. These debilitating conditions last for years and sometimes for life, often with a devastating impact on the quality of life of the sufferer. Traditional pain-relieving medications no longer work well, and there are often other symptoms, mood and sleep disturbance, for example, or chronic fatigue. Patients need a lot of support to help them manage their condition. Janice was not doing well. I wanted her to be able to access additional therapy and coaching to help her cope, but the only available service to which Janice could be referred was 15 miles away. She declined the referral. She was too debilitated to manage the 2 bus journeys that would get her there, and she could not afford a taxi. She was also highly sceptical that it would help, and in truth that was the main problem that I could not overcome. So she asked me to increase her pain medication. I was under pressure to get to my house calls and there wasn't enough time to support her further. I was not meeting her needs. I knew that, and that didn't feel good. I felt I'd failed as a doctor and I experienced something I can only describe as an ache in my chest. Much later, I saw this uncomfortable and distressing feeling defined as moral injury. The resources at my disposal were insufficient for delivering the standard of care I wished to give to my patients. Time, resources, services. As well as being the senior partner in my practice, I was also a primary care clinical director in my local integrated health board at the time. And in that role, I was involved in medicine's optimization strategies and service transformation. About a week after seeing Janice, I found myself in a board meeting in which there was intense scrutiny of prescribing variation in relation to chronic pain medication, specifically pregabalin. The drug was expensive at the time, and it also had the potential to have harmful side effects if it was used incorrectly. The board, not unreasonably, wanted to take action to ensure prescribing was within guidelines, and I was alarmed to see that my practice was in the top 5 highest prescribers of pregabalin in the borough. You can imagine I was a bit uncomfortable. I thought about Janice and the high burden of disease in the community that my practice served, an area with a high level of socioeconomic deprivation. I began to feel intense frustration that we were using resources so ineffectively across the pathway of care, and that we were not looking at this problem from the perspective of the patient and the outcomes that mattered. Often we had little more than a prescription pad to help, and this fell far short of what was really needed to improve outcomes. For Janice, increasing the availability of non-pharmacological support for her condition could have improved her quality of life. It would have enabled me to reduce both her medication burden and the number of clinic visits with me, which had not helped her at all. It might even have helped her to go back to work or at least improve her social functioning and well-being, but we did not know that because we were not measuring outcomes. Janet's needs were not being met, and nor were those of many others, and this was costing the system a great deal. Surely we could do this better and improve outcomes, reduce costs, and release healthcare professional capacity if only we took a whole pathway perspective. Without realizing it, I was thinking about value-based healthcare, which is a model of healthcare that focuses on improving the outcomes that matter whilst managing system resources more effectively. The more I thought about the issue, the more examples I could think of where outcomes could be vastly improved through relatively small changes to the way care was delivered, and I became ever more frustrated. And that is why I got into value-based healthcare. Thank you for indulging me. So, the situation we're facing in the world at the moment is healthcare costs are rising inexorably, but outcome improvement is not happening at the same rate. And part of that is changing demographics, of course, and the fact that many people are living longer but not necessarily healthier lives. And we also need to factor in the cost of innovation, of new drugs, new technologies, ever layering complexity on healthcare. And in truth, that's one of the main reasons driving costs within the system. So as I mentioned earlier, there's a recognition around the world now in many, if not most countries, that we need to think about how we are using our resources. So not just finance, but also human resources, because as the demographics change and as we have growing complexity of care, we're just simply not going to have enough healthcare professionals to deliver care in the traditional way that we have done perhaps in the NHS over the years. So we're going to have to do things differently if we are to maintain outcomes for the population and if we care about equity, because healthcare is always about choices. And if we don't think about how we're going to equitably use those resources, then we will grow greater inequities within the system as we start to, frantically try to improve outcomes. And I think we've known this for a while. So value-based healthcare is just a data-driven approach to thinking about improving outcomes that matter through measuring those outcomes and also how we use our resources. But it sits on a backdrop of professional movements like Prudent Healthcare in Wales, which talks about co-production, health equity through caring for those with the greatest health need first, really de-escalation of care, so a gentler form of medicine where we don't leap to the most invasive course of action and we focus on achieving the outcome for the patient in the lightest touch way. And of course, reducing unwarranted variation where standardization is appropriate. And GIRFT in England, getting it right first time through the work of Tim Briggs and others, is part of that because it looks at reducing unwarranted variation through evidence-based approaches, but on its own is not the whole value picture, of course, because it doesn't really bring in outcome measurement. Realistic medicine in Scotland, which is very similar to Prudent Healthcare in Wales. Choosing Wisely International, which was the movement begun in America to reduce low-value care. And my personal favourite, Slow Medicine from Italy, which is very Italian and talks about building health in the communities, slow food, and really, taking a more asset-based and building a health approach to this. All of these are aspects of value, I would argue. So when you think about value-based healthcare and when people talk to me about it, it's easy to get lost in what value is and how we might achieve it at a system level, because it's so vast and all-encompassing. And there are many things that increase value, whether it's an outcome for an individual or reducing waste in the system. So I find this approach helpful and chunking up into population, pathways and people. So thinking about value at a macro level, at a meso level and a micro level, always thinking about the outcome data that we want to see, equity and how we use our resources. So let's delve now into some more depth at each of those levels. So let's start with people. So people, of course, are not their disease. They're individual, autonomous people who will want to make choices about their health and care with us, and choices about their health seeking behaviours and choices about their healthy lifestyle or otherwise. We are autonomous individuals. So achieving an outcome is a team sport, isn't it? It's not just about the technical interventions of healthcare professionals, important though that is. It's our patients and our citizens are very much a part of that. But I would argue that this quote from Voltaire, which is one of my favourite quotes actually, is still true today. Now, admittedly, Voltaire didn't really like doctors and healthcare professionals very much. He thought we were kind of very quacky and suspect. But he said, doctors are men who prescribe medicines of which they know little, to cure diseases of which they know less, in human beings of which they know nothing. And I would argue that's still true, really. I mean, hopefully evidence-based medicine has taken us on a little way, so we know that hopefully a little bit more about what we're prescribing in terms of treatment. But the truth is, unless we ask and unless we involve patients in what matters to them, we don't really know what matters to them, and we don't know what outcomes they're getting as a result of their treatment. And randomized controlled trials tell us about efficacy, but they don't tell us what happens in the real world when messy life takes over and we don't really know what the outcomes are as a result of treatment. So outcome measurement and thinking about outcomes, both clinical and patient reported, is incredibly important if we're to understand value in healthcare. So clinical outcomes, of course, are often measured in clinical audits, which have grown up over the years, which are incredibly useful, but tend to come as a report sort of annually. So I think it's very helpful if we can be on a journey to move towards clinical outcome measurement much more on a rolling basis, and to put that alongside patient reported outcome capture. Now, obviously, there's quite a bit of data infrastructure building involved in that, and that's a lot of the work that needs to happen to move towards a value-based system. I'd like to ask you a question. Do you think that clinical outcome and patient-reported outcome data has the same esteem in healthcare systems as financial and process data? And do we invest as much in capturing it? Perhaps we can talk about that at the end of the session, as it's a bit of a bugbear of mine. But in terms of patient-reported outcomes, an outcome is a milestone, an endpoint, or a consequence which matters to a person. So when we think about patient outcomes, traditionally, perhaps we think about looking at effectiveness of an orthopedic procedure, like a hip replacement, so in episodic care, for example. And it's true that it has its use there, but it's also useful in chronic disease and cancer, where we might use that data in a very different way. So patient-reported outcome measures are essentially a structured communication between a clinical team and a person receiving care, and therefore they can be really useful symptom trackers, because the patient-reported outcome data, if it's condition-specific, like the KCCQ in heart failure, we can track symptoms over time. And that's an incredibly useful tool to support self-management and person-centered care and the care of an individual patient. And I suppose one day, when we have enough information and real-world evidence, we'll be able to use that information to support shared decision making. So if I'm asking a question about whether or not I should have a treatment, I can have information about what the likely outcome is for someone like me, not just what happened in the randomized controlled trial for an idealized population. At an individual level, it's also really useful as a trigger for key conversations. So just as an example, in my experience, we're not very good at identifying palliative care needs in people with non-malignant disease. PROM tracking gives a much more objective feel over time of how people are doing, and it can be a good way in for key conversations around when new decisions need to be made in somebody's care pathway. Again, at the person-centered level, if we are to improve value in healthcare systems, we need to really think carefully and purposefully about how we support self-management and raising patients or raising health literacy in the population and increasing people's ability to interact with us. So patient activation, in other words. Now, supported self-management, when I worked in health boards, was often, the sort of thing, a tier 0 intervention on a health board plan with no kind of work next to it, or certainly no budget next to it. But I would argue that supported self-management, when we're growing a very large population living with chronic ill health, is as important as surgery or medicine. And we need to be thinking about how we design it, how we co-produce it with patients, and how we fund it, because that is what's going to improve people's outcomes, reduce disease exacerbation, and so not just improve people's quality of life, but also significantly reduce acute healthcare utilisation, and there's plenty of evidence for that. So is it acceptable to measure outcomes in practice? Can you embed it in care? And the answer is absolutely yes. My own first experiment into this was actually in a Parkinson's disease clinic in Southeast Wales, where we tested measuring outcomes in clinic before patients saw the clinical nurse specialist. And what we found was really striking. Even before we got any data of any great, volume, we noticed that the very act of completing the outcome survey had an initial impact on the consultation. So it enabled people to prioritise what they wanted to talk about in the consultation. So it hugely reduced the power differential between the clinician and the patient and their families. And it also had the effect of raising people's awareness about their condition, because, as you see, this is a multi-symptom disorder. And for some of those symptoms, patients didn't actually realise that it was due to their Parkinson's. So they were not even mentioning the issues they were having because they didn't know. And this raised their awareness and enabled them to address issues they hadn't even touched on before. It's incredibly powerful. Once the data started to come in and we aggregated the data, we saw straight away that there were a few very different cohorts within the clinic population that had different needs. So, like many NHS clinics, we had a one-size-fits-all approach and everybody went to the same clinic, but we found that new patients had very different symptom burden, of course, and needs to other patients. So they needed particularly psychological help to help them cope with a new diagnosis, which was quite devastating for many. Stable patients were probably being brought at great inconvenience to them too much to the clinic, whilst there wasn't enough time, and there certainly wasn't a multidisciplinary approach to those with advanced complex disease for whom their healthcare had become a full-time job because they were coming back and forth to see different professionals. So off the back of this data, we were able to redesign the clinics and quantify the resource that would be needed for each of those cohorts within existing resources, by being lighter touch with those that were stable and not needing so much intervention, but able to provide the more tailored support to both the new and the complex segments of that population. So that's person-centred care. What about pathways? So this is probably one of the most important things about value-based healthcare, is that we need to view the pathway as being integrated and whole from prevention through to end of life, because that's the only way we can understand whether all of the activities across the pathway are being adequately resourced and contributing to a better outcome for the patient. So we need to move away from thinking about episodes of care and service-based pathways to thinking about the patient journey and thinking about the activities that people need across a pathway of care, across that entire journey from prevention to end of life. Why is that? Well, in my experience, and I also have done this many times as a GP, we tend to think about design from our own perspective and our own service and leap to solutions for service delivery based on what we already know. So it's absolutely deliberate that no services are mentioned on this slide. It's about redesigning care from the ground up, thinking about what patients need in terms of prevention, if that's relevant, timely diagnosis, optimizing intervention, and then how we do the follow-up, particularly in chronic disease where this is happening over a long period of time, how we use digital technologies, and then on, of course, into palliative and end-of-life care if we're talking about life-limiting conditions or cohorts of people with similar needs like palliative care or older adults with complex comorbidities. And all the while thinking about a forensic analysis of each step, thinking about, is this improving outcomes, and are we making best use of resources to achieve that same outcome? Which sounds obvious, but actually the radical way in which we need to innovate care now is going to be quite scary at times, and we need to assure ourselves that we're at least not doing harm and hopefully actually making things better than they currently are for patients whilst better utilising resources. So it means taking a critical look and reducing low value care as well, which might mean redundant steps in the pathway, or it might mean reducing less effective interventions, or it might mean cutting out unnecessary outpatient appointments that are not adding value to the patient. So it really is a forensic analysis. So, for example, this example is about how using outcomes in practice, in this case, a heart failure clinic, actually allowed remodeling of the clinic and much better optimization. So the problem in this clinic was that it was totally overburdened, something which I'm sure you'll all recognize. The outcomes were poor, such as we understood them, and we inferred that from the high 30-day readmission rates for heart failure in the area. And basically, people were taking too long to be assessed and too long to be optimized. So because there was such a burden on the clinic, we were not getting people into the clinic quickly enough after diagnosis. And the titration period for medication to get people optimized was too long. And sometimes people were being lost to follow-up, which was even worse, So this really needed to be sorted out. And there was really suboptimal use of nursing time, and that one-size-fits-all model leading to overburdening of staff was causing a lot of burnout and distress, as well as the impact on patients. So what did they do? Well, the lead nurse persuaded her colleagues that they should start measuring outcomes. And I can tell you they weren't very happy about it at the beginning, because it was seen as another task, not unreasonably. But they started to measure parts of the ICHOM standard set for heart failure, the International Consortium for Healthcare Outcome Measurement, pulled together using quite a robust methodology, outcome sets that matter to patients. And one of the questionnaires that they used was the KCCQ-12, which asks patients about their symptoms in heart failure. And what you see in this slide is an example of two of those questions where patients are asked, how many times in the last 2 weeks did you have swelling in the morning, swelling of your extremities, or how many times did you have to sleep sitting up? And what we found, sort of a bit like the Parkinson's example, was that we found different cohorts of patients within that population, and about 2/3 of patients did not report either of these symptoms at all in the last 2 weeks. So in other words, they were pretty stable. So as long as they were fully titrated, technically they didn't really need to be formally seen in the clinic at all, you could argue. Whereas consistently about 15% had these symptoms every day. So these patients are either undertreated or have advanced disease and perhaps needs palliative care as well. So again, it enabled within existing resources a remodeling of the clinic to tailor towards specific needs, whether that was titrating or whether it was having that conversation about palliative care and having a bit longer with patients. And they did that. And, you know, the impact on the 30-day readmission rate was unbelievable. I mean, it reduced it by a huge amount. But it also made the lives of the staff and patients a heck of a lot better. So it was a really powerful example of where you might have thought adding another task would overburden them still further, but actually had a really positive effect. They also measured PHQ-2, so they were screening for mood disorders. And unsurprisingly, what we find in in chronic disease, chronic physical ill health, is that consistently about a third of patients have significant mental health needs as well, which need to be addressed. So PROMS as a needs assessment, as well as a measure of effectiveness, it is really important and very, very helpful with service redesign. So the other point to mention is that this was done initially within existing resources through sort of rejigging how patients were seen within the clinic. But because the team did so well and, you know, really stunningly improved outcomes, could prove that they'd reduced acute healthcare utilisation within the health board, gave the board such confidence in that team that when they then did go to the board for resources to expand aspects of their services into the community, they were able to attract funding, something that they hadn't been able to do for the previous 5 years. And there is a case study written up about this that is available through Swansea University. So you might say, well, that's all great. You're just talking about individual conditions, but life's not like that. And people have comorbidities. And how do you do value-based healthcare in urgent care? And how do you do value-based healthcare in primary care? And are they the unicorns of value-based healthcare? In other words, does it really not work for urgent and primary care? So my perspective on this again is that urgent care and primary care are service areas. And we need to look at value-based healthcare through segments of the population, segments of people with similar needs. So there will be multiple different segments coming through primary care and urgent care. And the key thing, I think, is to understand what the role of primary care and urgent care is in the care of that segment of the population, if that makes sense. Because if we do that, we can start to understand then what resourcing is needed in primary care. At the moment, there is very inadequate resource in the community to manage chronic disease. And this is one of the reasons why we're seeing the system running so hot and huge overburdenment of acute healthcare services. It's not the only reason, of course, but it is certainly one of the reasons. So I find this approach helpful when thinking about value. So again, you're banned from talking about services as the first port of call. And what we need to do is, how do we segment our population to see how we can improve outcomes for groups of people with similar needs? And how do we think about addressing those evolving needs? And how do we measure the outcomes and the costs associated with that to keep us on track across this whole pathway? So this is the killer slide for me, for the whole. If you only take one slide away, this is it, because it's about this top left-hand corner and really using this as your design blueprint, I guess. And then what might the activities for value be across that pathway? Well, as we've already talked about today, person-centred care and supported self-management will be really, really important, whether you're in primary care or secondary care. But I would argue that from a value perspective, understanding how we support patients to live with chronic disease in the community will be a really, really high value intervention to help us now, as well as moving more into the prevention space. But actually, there's a lot we need to do right now. Stewardship. So yes, there is something about reducing unwarranted variation and low value care. So tackling prescribing variation that's unwarranted, polypharmacy, over-testing, and all of that bucket of stuff. Chronic disease management. How do we get back to doing the basics rigorously as much of the time as we can? And of course, that was one of the things that the quality and outcomes framework for general practice was quite good at doing in the earlier days. We've lost a little bit of that. How do we systematize that again and make sure we do that really well, involving patients? And then again, with older people, how do we flip it so that it's more holistic? We're thinking less about individual conditions and more about managing multimorbidity. And there are, in fact, outcome data sets that apply to older people, moving perhaps into multimorbidity and frailty, thinking about how we're avoiding deconditioning and harm and unnecessary hospital stays that people don't want. So just a final story or two. Thinking again about urgent care. This was a piece of work that came from a question: how do we do value-based healthcare in urgent care? And I decided to look at the data from Welsh Ambulance and find out what the major causes of conveyance to ED were. And the top three were falls, respiratory problems, and palliative care. So that's quite interesting, isn't it? Because the system responds to queuing ambulances outside ED in a particular way. And we did have this problem. It was in the news in Wales. And we tend to put sticking plasters on things. We try and tackle it through flow. Now, I'm not saying we shouldn't have good flow through hospitals. Of course we should. But actually, if you're not tackling the root cause of why those people are coming there in the first place, we're never going to create a sustainable system. So we looked at palliative care as one of those segments. And we made a connection between the Welsh Ambulance Service and the palliative care network, two groups of people who'd never really interacted before. And we merged their data sets and their outcome data sets into this dashboard in Wales called the Last Year of Life. And we were able, through that intelligence, to understand which patients were underserved in terms of palliative care and link that very clearly to the resource utilisation in the ambulance service, which of course then gives you really good evidence to start thinking about how you reallocate resources to meet that need in the community and reduce those conveyances by ambulance to ED, which benefits everybody, not just the palliative care patients to whom that applies, but of course other patients who really do require conveyance to ED for emergency treatment. So data triangulation and that boundary spanning collaboration are really key ways of working when we're thinking about trying to increase value for patients across whole pathways of care. Very often we try and improve things in our silos, don't we? But we need to try and think more broadly and how we work across those boundaries. Not easy to do, but important. And finally, populations. So how do we increase value at a population level? Well, we need to segment the population, as I said, and clearly what falls into this bucket of interventions is the whole prevention agenda, from public health through to secondary intervention, which will probably improve outcomes within a shorter time horizon, and so is a good place to start, I think, if you're on that value-based healthcare journey in your organisation. And then there's something important as well, I think, about modernising health technology assessment. So understanding how we can, as we embed outcome measurement into our systems, how we can understand real world data, not to replace randomized controlled trials and traditional evidence generation, but to augment it so that we understand what happens in the real world and messy life with these high cost new interventions that are coming through in the next few years. Yes, so one other thing I didn't mention was the link with the green health agenda. So clearly healthcare and the green agenda are both about consumption. So we're trying to reduce unnecessary consumption as part of value-based healthcare, and that's certainly what we're trying to do with the carbon agenda. So the two are inextricably linked, and that can be quite a helpful link to make, I think, in terms of engagement with our colleagues and explaining what we're trying to do here. This is not about arbitrary cost cutting. So finally, before we open up for discussion, just some points really. I think partnerships for value, so that boundary spanning connection with colleagues in different disciplines, but which might have related impacts across whole pathways of care, is really, really important. And also thinking about how partnerships can help us problem solve within our clinical area. A culture of stewardship. So I think it's easy sometimes, certainly I did it myself as a clinician, is to bang the desk for more resources. And don't get me wrong, sometimes more resources are needed, but we have to do our bit and look critically at whether there's anything we can do to reduce unwarranted costs and variation within the system, and that's definitely part of it. So that's stewardship culture. But the quid pro quo to that is smart investment. And this is a conversation I have with finance directors a lot, is yes, people will be good stewards of your resource, but your skin in the game is you need to invest in the smart stuff that's going to improve outcomes and reduce healthcare utilisation, things like supported self-management interventions. Reducing unwarranted variation remains very important where standardisation is required, so rigour around chronic disease management, GIRFT, and those things remains important. And of course, leadership and data transparency. We're not nearly transparent enough about data, and we need to work on that. So I hope when value is our true north, we might start to make some progress towards the healthcare system we want to see in this country and wider, and hopefully that will bring back some joy into those of us who work in healthcare systems, because I know it's a really tough place to be at the moment. Thanks, Matthew. Thanks everyone for listening. I'm going to stop sharing.
Yeah, brilliant. Thanks so much, Sally. Yeah, fantastic presentation. We've already got some questions coming in. We've probably got a good 15-20 minutes actually to get into discussion now. I will come to the audience questions in a minute, but I've just got one or two for you first from me. I guess one on my mind, you know, and thinking about where Q members will be coming from is, how does kind of quality improvement and improvement fit into this? Is it a challenge? Do you see it as a challenge to improvement? Is improvement part of this? Or yeah, could you say a little bit more about that? That'd be great.
Of course, yeah, and improvement is absolutely part of this. I see value and quality improvement like that, and I think it's the way I look at this is that we can improve quality around improving processes within our service, and that is an absolutely important part of value. But without the whole pathway approach and without patient outcome data, it's very difficult for QI to work across the whole pathway. So value and quality, I think, become absolutely complementary in that regard. And I know some people would, I'm not an expert in this, but I gather there's a whole thing around quality assurance, quality management. And so what some people would call quality management, I believe, has some relation to what I'm talking about with value. But the key bits are, whatever we call it actually, is about the whole pathway approach, the need to do different things across the whole pathway, and the need to understand outcomes and costs, because we're trying to change the way decision makers make their decisions. And that's the nuance, I think, in my opinion.
Yeah, great. I've definitely had that kind of more holistic approach to quality management in mind, and could see a lot of the connections across. Great stuff. All right, I've got plenty more questions, but I better go to the audience, Hunter. So we had one from Jenny, which was, yeah, what do you think are the kind of forcing functions, the system changes that are needed to enable the shift?
Yeah, great question, Jenny. So I think there's something about the infrastructure that needs to be there, and the culture, obviously. So the culture of healthcare systems at the moment is not to use outcome data to guide our decision making. We use process data, and we need both, I think. So rather than, of course, the time that people wait for outpatient appointment is important to that person, but actually, why do we have long waiting lists? Is it because we haven't provided the right interventions in the community that might have met people's needs in a different way earlier? It doesn't give us enough, and it leads us to put sticking plaster solutions on making the waiting list shorter, rather than asking what are the needs of the patients and how do we meet them, and then what is the role of outpatients in that. So I think what we need to drive is a more rounded view, a more whole pathway view, and a more root cause analysis approach to tackling need rather than managing demand. And the system at the moment is really set up to manage demand. And it's very obvious with what's just been driven through, and this might be a bit controversial, so apologies in advance, what's been driven through with the GP contract in England over the last couple of days around forcing same-day access over everything else. Now, of course, access is important, but there's going to be an impact of that for other patients who might have chronic ill health, need more longitudinal continuity of care, and we might lose something very important there. So so it's a great question, Jenny. There's a lot to change for sure.
Yeah, and Sally, just while we're on some of those enablers, I'm just going to bring one in from Aidan, which was about kind of the data transparency and the data that's required to support this. He's got a specific question around kind of any thoughts you have on how we can make data across and between organisations more accessible and interoperable, so that we get that wider picture. I guess, while we're on data, if there's any other thoughts on the kind of infrastructure, skills even that we need to kind of make that shift towards the data that you were talking about.
Yeah, data is oh yes, Lordy. I went down a real data rabbit hole. There's so much to fix, isn't there? So I think there are two main points that come to mind that sort of cover most of it. One is data interoperability, which you've hinted at. How do we share data across systems? And that leads us into data standards. So we need to be far more focused, I think, on data standards. And that means things like clinical coding, making sure that we're all collecting the same data in the same format, essentially, so that we can compare and share across systems. Really, really important. At the moment, a lot of the data quality is bad. and that disincentivizes people from using it and collecting it. And part of that issue is transparency. So people say, oh, we can't share that data because it's poor quality. Share the data and the quality comes next, because nobody likes to be sharing poor quality data. So we need the same attention to, for example, clinical data, clinical and patient reported outcome data, as we do to other process and finance data. I made a tongue-in-cheek comment to a finance director, a good friend of mine, recently. I said, Hugh, tell me what would happen if, in March you went back to government and you said, oh, do you know what, I've been really busy, so I've only managed to do 50% of my finance data accounting this year. Sorry about that. What do you think would happen? And he said, well, I'd probably be sacked. He said, no, I would be sacked. So I said, okay, so what happens about clinical audit then? Nothing happens. There's no really any, it doesn't have parity of esteem. So we've got incomplete data to inform our decision making. And these are the sorts of things we urgently need to fix with the data. We need to be very clear what we need, and we need to be brave and transparent about it, in my opinion, because that's how we make things better. But I guess you all agree, because you're in the Q community.
Yeah, lots of nods, I'm sure. Yeah, lots of nods from me and colleagues. I mean, just while we're on data, anything else on? Yeah, I mean, you've talked about the need for that kind of parity of esteem. I think in the heart failure example you gave, you talked about the feeling that it was a request for like more data on top of what maybe the team are already collecting. Is there anything to say on how this move, it's not about more data, it's new data or different data, or it could even be collecting less data but just different data? Anything else on that shift?
Yeah, so if you go to other countries where they are in very low resource environments or very challenging environments, so I'm thinking about Africa and I'm thinking about hyper remote Australia, where the logistical problems are huge. What you find there with the teams is that they will start with the problem that they're trying to solve and then figure out what is the absolute minimum data set that they can get away with to understand whether they are improving outcomes. So it might even be as simple as one outcome data point. So that was certainly the case in diabetes in remote Queensland, and a very simple mental health outcome measure for a rural maternal mental health issue in Kenya. So it's starting with the problem and also starting with the patient segment. So Andrew's asked a really interesting question in the chat. How do you do this to support frequent attenders and high intensity users? And again, it's more going back to the segments of patients. So are they high intensity users whose mental health needs are not being met, or are they high intensity users who have a chronic physical disorder, and therefore what can we do earlier on in those pathways to prevent attendance, rather than thinking about the service lens and how we push people back. So I know that's not a very palatable answer, because it requires a lot of deep work and probably a bit longer to fix. But I've worked on high intensity users for many years, and the sort of traditional approaches to this just don't work, in my experience anyway. So thinking about the needs of grouping up the sort of different needs of the people who are in that category, and figuring out how we're going to do that differently is really important. And some have there are some things we can't reverse because it's been so many years of things to unpick, but essentially we need to go back to that segmentation.
Yeah, great to pick up Andrew's question. Yeah, he added a few thoughts as well further down around supporting that. I think the need to kind of incentivize that multi-agency pathway.
Yeah.
Which obviously requires, as he says, much more radical change, the kind of culture and process of commissioning. Great stuff. So next question we've got from Claire. This is really from the perspective of anyone leading kind of, say, national programs of work and wanting to evaluate whether that program of work is really, meeting the value-based healthcare principles. What kind of criteria would you advise they use then to evaluate their work and their programs against value-based healthcare? Claire's given a few examples, but it'd be good to hear from you, and we'll pick those up.
Yeah. So examples. I'm just reading what Claire's written in the chat here. So yeah, I mean, it depends on what you're trying to achieve, but essentially you need to understand, I think, from a value perspective anyway, whether that intervention is actually improving the outcomes of people that are going through it, and also what the impact might be on healthcare utilisation as well, and what the costs associated with that would be, because it's the cost and the clinical time, and any other resource inputs that we would need to understand there, essentially. I hope that's answered your question, Claire. It's bespoke, really, depending on what it is that you're doing. But the list that you've put there is basically correct, from what I can see.
Great stuff. And I think Claire might want to follow up with you as well on some more specific questions on LinkedIn, which we said that you were happy to do that. So I can see the questions coming through. We've got a few more minutes, so we'll get to a few more, but keep them coming. If we don't get to them, Sally's really generously agreed to kind of share some responses to those questions in the follow-up email, or like I say, if there's direct questions you want to ask of Sally, she's happy to take them through LinkedIn as well. So like I say, we've still got a few more minutes for a few more. So I'll bring one in from Nitesh, which I'll read actually. So he says, would be really interested to hear thoughts on how value in healthcare is defined. So he uses like Michael Porter's original concept of outcomes and experience against cost to deliver them versus kind of newer viewpoints of outcomes and experience against resources to actually deliver the outcomes. So he says in his organisation, introduced value management as one of the tools within a quality management framework that we touched on. But they say, I think that the cost domain must be an element within value-based healthcare, which helps separate it from more kind of traditional improvement work. So anything else on that kind of actual definition concept of value?
Yeah, I agree. I mean, essentially, it's the outcomes. It's the outcomes that we achieve, the outcomes that matter to people. So some people use outcomes to mean reduced attendances at ED. That's not an outcome. Not in the context of value-based healthcare anyway. I mean, it might be a desirable piece of information for us to know and look at, but that's not what we mean when we mean outcomes that matter to people. So this is patient outcomes, clinical and sometimes patient reported, that we can manage to collect them, that is appropriate to whatever you're trying to measure. And you're right, the cost inputs are very, very important, including the staffing inputs and all inputs. And very often, what I also find a really helpful approach, especially in the NHS, is to think about the cost of not doing something, because very often we don't do something because of a cost pressure, and actually then that is going to create an even bigger cost pressure somewhere else in the system. And we know that, and it's very frustrating to many of us in this virtual room, I'm sure, but it is possible to estimate the costs of not doing an intervention, if you see what I mean. So so I think the definition is I mean, the Porter definition is very simple. It's the outcomes that matter to people for the, relative to the total cost. I think the main difference that that I would add from a European point of view is that we also care about equity. So we need to think about allocative value and how we allocate our resources across whole pathways and between programs of care, and make those decisions because we care about equity and universal healthcare. So for me, trying to think about this in Wales, I was very conscious of a mashup, if you like, between Michael Porter and Elizabeth Teisberg's theory and Muir Gray, and what he was saying about, societal and allocative value as well, because that's the reality of our decision making and what we care about, isn't it?
Mm-hmm. Great stuff. We'll keep them coming. So we've got another one from Anya. How can the medtech sector and NHS partner better to achieve value-based healthcare, especially when data visibility and accuracy pose a huge kind of barrier even within the health system? So that question on the connection with medtech and how the NHS can work with that sector and partner with that sector to progress this.
Yeah, hi Anya, nice to see you on the call. So medtech is interesting because I think often with medtech interventions, there's maybe less evidence as we want to introduce that new technology into the system. So that real world collection of data to make sure that that intervention is doing what we think it's doing is ever more important. So I think there's an interesting relationship between value-based procurement, as you know, Anya, and in the NHS. So I'm very interested in NHS England's new value-based procurement approach, because I think that will foster these value discussions between industry medtech partners and the NHS, because it has to, and we have to move to a new form of contracting that is much more outcome focused and using at times outcome data as part of that contracting mechanism. That's going to be, that's a big shift. So it takes trust, takes confidence and bravery as well, I think, on behalf of healthcare providers who haven't really operated in this way. And I noticed Jacqueline Watson's comment as well about wound care. I feel your pain, Jacqueline. Wound care is a really good example of this, of where we maybe use cheaper products that actually may bring higher costs into the system through needing more nursing time or whatever it happens to be, because they need to be changed more regularly. Thinking about how we understand the problem together and how we use outcome measurement for value contracting will be really important. But the other thing I would say is the industry, rather than developing products in isolation, should be problem solving with us around innovating to solve the problems we see in the healthcare system. And there are some places around the world that do this really well, particularly in Catalonia in Spain, where they have a really good partnership between industry and the local healthcare providers that really does foster innovation in a very good way.
Great stuff. And we will just take one final question then from Fred. So Fred says, things like reducing attendance at ED are not outcomes, but we have such a dinosaur system that uses this measures as a kind of safety net. So how would you broach a conversation with a chief operating officer, say, that starts with looking at attendances in ED, moves the conversation enthusiastically to how focusing on outcomes that matter to patients can really just be about reducing kind of ED attendance? And I think just to broaden that out, I was conscious, I'm sure a lot of people on the call have been nodding along, but, there's lots of examples in the book, isn't there, of how you successfully persuaded people who maybe didn't start from the same place that a lot of people on the call will be. So it'd be great to hear reflections on that and specifically on Fred's point.
Yeah. Hey, Fred. Good to see you. Yeah. So I think the first thing is people are not wrong. So I'm not criticizing people who are thinking about ED attendances, because that is the problem as it presents itself. So meeting people where they are, I think, is really important, because everybody's under immense pressure and doing the best they possibly can. So I'm certainly not saying don't go in there, and I'm not saying go in there and say, oh, this is all rubbish, you need to chuck it out the window, because probably you'll get short shrift. But I think getting people to think back to root cause. So asking why have we got all these attendances, and who are they, and can we group them into segments? Or if people don't like the word segment, use another word. Use the language that people like where you are. And if they don't want to use the word value, great, don't use the word value. Use quality management, use something else, whatever works in your organization. It's much more about the principles, which I've tried to kind of go through today, and understanding the needs of different groups of patients, and then tackling those at their root cause to the extent that you can. And then when you add those up, that in over time is going to have an impact on ED attendance, whether it's, you know, if you do your falls, your palliative care and your respiratory problems as the first 3 chunks. Now you've got to do flow as well, of course you have, but that's how we go about meeting people's needs differently within the community setting, and that's how we rebalance care to the greatest extent we can away from hospitals. You know, shift left is not a new statement. I've been hearing that as a GP for the last 25 years. And we'll never manage it until we radically redesign and meet people's needs rather than manage demand. And those are 2 very different things.
Great stuff. Okay, so we're going to start to bring things to a close. That's been fantastic, and yeah, it's really kind of challenged and progressed my thinking. I'm sure others will feel the same.